In today's video, we will discuss about organomegaly evaluation, mainly hepatosplenomegaly, which is one of the most important aspect in per abdomen examination. So the first rule which we have to remember whenever we think of palpation or examination of liver and spleen is just because the organ is palpable, don't consider it as enlarged. This will apply particularly to liver. What happens is in some normal healthy adults or in cases of COPD, emphysematous lung, the diaphragm will push down the liver. So when we try to palpate, we will get some part of liver below costal margin, but it does not indicate the liver is enlarged unless you measure the liver span. Now, how to measure liver span? We have to mark the upper border and lower border, and we have to take the measurement. So for the upper border, usually during percussion from second intercostal space, in the mid-clavicular line, we will be percussing down. All these spaces will be resonant note. But usually in the fifth intercostal space, we will get the dull note. And most often that will be the upper border of liver. But to confirm, we need to ask the individual to take deep inspiration and we can re-percuss again. During that time, that particular space will be having resonant note again. So this will confirm the presence of upper border of liver in that space. So that will be the upper margin. Coming to lower margin, during the palpation itself, when we start palpating from the right iliac fossa upward, we will be getting the lower border of liver. That point we need to mark. So upper and lower markings should be measured. That will give the actual liver span. So normally it will be up to 12 centimeters in men and up to 10 centimeters in females. So if it is more than these numericals, we have to consider it as enlarged liver or hepatomegaly. Majority of the times during palpation, we get roughly about 2 to 3 centimeters of liver below right costal margin, and that is absolutely normal. But in some cases, we might get up to 5 or 6 centimeters of liver below right costal margin. During that time, don't comment it as hepatomegaly. Always check for the upper margin of liver. In some individuals, as I mentioned, for example in COPD emphysematous changes, the upper border might not be in its usual place of 5th intercostal space. It might be displaced downwards to 6th or 7th intercostal space. That's why the lower part is more palpable when we are examining. So in that case, mark the upper border at 6th or 7th intercostal space and take the lower margin as well and measure the span, then only consider hepatomegaly is there or not. But when it comes to spleen, this is quite different. Usually spleen is hidden behind the rib cage, and to cross the left costal margin, it has to be enlarged 2 to 3 times of normal size. So if you are able to feel any part of spleen below left costal margin, it is an indication of splenomegaly. And this splenomegaly is more evident during percussion. For example, you might be knowing about Castell's method, drop space percussion. So what happens here is in Castell's method of splenic percussion, the lowest intercostal space in the anterior axillary line should be percussed during the full inspiration by patient. So normally in this space, we will get the resonant note. Suppose you get a dull note in that particular space, it is an indicator of splenomegaly. This is nothing but Castell's method of splenic percussion. So the points to be remembered here is lowest intercostal space and percuss in the anterior axillary line. When it comes to drop space percussion, this is an semilunar imaginary space bounded by the 6th rib superiorly, the mid-axillary line and costal margin inferiorly. So in this particular space, usually when you percuss, it will be a tympanic note. Suppose you get it as dull note, it is again an indicator of splenomegaly. There are numerous other causes for dull note in this drop space, but when you have splenomegaly in mind during examination, this is one of the best clue we can say. Now we understood when to consider hepatomegaly and splenomegaly. We will now discuss about the grading of this organomegaly. First is about hepatomegaly grading. So in the right costal margin, we consider hepatomegaly if the liver span is more than 12 cm in males or more than 10 centimeters in females. This is the first point. Then for grading, look for the extent of vertically downward displacement of liver below right costal margin. So if it is less than 3 centimeters, we call it as mild hepatomegaly. If you are able to feel 3 to 5 centimeters of liver below right costal margin with increased liver span, this is a must for all this grading. In that case, we call it as moderate hepatomegaly. And if it is more than 5 centimeters below right costal margin, it is massive hepatomegaly. So once you find the grading, we have to think of several causes which might be leading to hepatomegaly. For example, for mild enlargement, it can be due to fatty liver, acute viral hepatitis, early stages of cirrhosis, or mild congestive heart failure. So some form of infiltration to the liver tissue is causing enlargement. Whereas for moderate hepatomegaly, remember these causes: liver abscess, alcoholic hepatitis, chronic hemolytic anemias, for example thalassemia and sickle cell anemia, as well as some storage disorders like amyloidosis or hemochromatosis are the reasons. When it comes to massive hepatomegaly, that is more than 5 centimeter downward displacement, just remember a mnemonic, that is MNOP. So M stands for metastasis, N is nutmeg liver, that is nothing but right-sided heart failure or tricuspid regurgitation. If it is severe, it can lead to massive hepatomegaly. Whereas O stands for outflow obstruction, for example Budd-Chiari syndrome, and P is primary tumor, that is hepatocellular carcinoma or polycythemia vera. In general, whenever there is organomegaly, try to think in this way. Always try to fit into ICH. I stands for infections or infiltration or inflammations. For example, when it comes to infection, viral hepatitis, malaria, typhoid, all these might lead to hepatomegaly. Infiltration due to amyloidosis or hemochromatosis, we can say. Inflammation due to any cause, for example alcoholic hepatitis, can also lead to hepatomegaly. C stands for congestion. So the backward blood flow because of right-sided heart problems can lead to congestion of liver, leading to hepatomegaly. Usually it will be tender hepatomegaly. And H stands for hepatocellular carcinoma or some other metastasis. So just by remembering ICH, we can find out the cause for hepatomegaly. So now you have seen defining hepatomegaly, grading, and few of the causes. Now how to decide what exactly is causing that hepatomegaly? For that, during palpation, focus on few things. For example, if the liver is soft, smooth and tender, think of congestion. Usually liver is insensitive to pain, but sudden stretch of the capsule of liver in cases of acute hepatitis, early stages of congestive heart failure, that sudden stretch will lead to tenderness of liver. If on palpation there is firm, sharp and non-tender liver, think of cirrhosis, mainly the early stages of cirrhosis. If you feel it is stony hard, nodular and quite irregular, always think of carcinoma. So not only the measurement, but the feel of liver's surface, border, all these things will help us in finding out the cause for hepatomegaly. Now regarding splenomegaly, we know that spleen will not enlarge, unlike liver, vertically downward. It will have enlargement in diagonal axis towards the right iliac fossa. So usually the palpation starts from the right iliac fossa towards left costal margin. And as we discussed earlier, any amount of spleen which is palpable below left costal margin is considered as splenomegaly. But based on the extent which is felt, we can grade splenomegaly as well. For example, if it is palpable for up to 1 centimeter till 4 centimeters, we call it as mild splenomegaly. 4 to 8 is moderate splenomegaly, and more than 8 is massive splenomegaly. And usually in this case, it will be crossing umbilicus. That is one more clue towards the massive splenomegaly. Regarding the causes for all these grades of splenomegaly, for mild enlargement, there might be some infections or inflammation as cause. So we can remember with the mnemonic TIME. T stands for typhoid, I is infectious mononucleosis, M stands for malaria, E is infective endocarditis. So in these infective or inflammatory states, there will be reaction by the spleen for the acute insult leading to mild enlargement of spleen. For moderate enlargement, there should be some back pressure or congestion by the blood. So the causes will be portal hypertension or some infiltrations like acute leukemias and lymphomas. Also, commonly hemolytic conditions can lead to moderate grade of splenomegaly. For massive splenomegaly, that is when spleen is palpable for more than 8 centimeters below left costal margin, we have to remember important causes. For example, chronic myeloid leukemia CML, myelofibrosis, Kala-Azar and Gaucher's disease. And one more discussion when it comes to splenomegaly particularly is how to differentiate spleen from enlarged kidney, left kidney. So there are some clues. For example, whenever we are palpating, try to get above the palpable organ. So if you are able to get above the upper margin, it will be left kidney. If you are not able to get above the organ, it will be spleen. And if there is a palpable notch, it is nothing but spleen, because there is no such notch in case of kidney. And during percussion, if it is splenomegaly, you will get dull note, which we have discussed already with some named methods like Castells and drop space percussion. Why? Because this enlarged spleen will push the bowel away. Whereas if the kidney is enlarged, when we percuss, there will be resonant note, because the descending colon sits over the enlarged kidney as usual. That's why you will get resonant note. So this was about the discussion about clinical examination. But what are the red flag signs we should utilize when we are treating a patient of organomegaly? Mainly, if the liver is tender, it will indicate rapid stretching of the capsule. So think of acute causes like acute congestive heart failure, acute viral hepatitis or liver abscess. If you feel nodular or hard liver, it will always indicate malignancy, either primary HCC or metastasis. If there is splenic rub or severe pain during spleen examination, it will indicate splenic infarction due to some massive embolus. And also, as mentioned, if there is massive splenomegaly, always rule out the listed causes like CML, myelofibrosis, malaria and Kala-Azar. So when you are examining for organomegaly, always try to measure the span of that particular organ, then only consider it as enlarged or not. So once you find it as enlarged, try to grade it. Grading is important. And also feel for the other features like the surface or margin, which will give numerous clues regarding causes for organomegaly. And for causes, you can remember the mnemonics which are discussed in this video, or simply you can recall ICH: infection, infiltration, congestion and hemolysis or carcinomas. So this is the overall discussion regarding clinical examination related to organomegaly. Save this video, make notes of it and try to apply all these things when you go to ward side. See you in another video. Thank you.